Hi guys, welcome back to the Preparator NEET Assess. This is the part 2 of the COPD video module, and in this part we will discuss the management of COPD. There is a reason why I have made these videos as two separate entities. The reason is the part 2, the management of COPD often gets changed. Every year the gold guidelines get updated, and I would recommend that postgraduate students and those who are going for NEET Assess should definitely be aware about the latest changes incorporated into the management of COPD. So this video lecture is going to be based on the gold guidelines for 2022. Okay, now before we start discussing how we manage a case of COPD using the gold guidelines, let us first start by making a problem statement. This is the usual approach that I follow for easy understanding as well as easy remembrance of the stuff for the disease management. So let us make a problem statement. What are the problems that patients of COPD face and how can we address them? Okay, so what are the problems that COPD patients can face and what needs to be addressed? Number one, these patients experience hypoxia that is indeed responsible for development of pulmonary hypertension, so that probably needs to be addressed, right? Number two, these patients experience dyspnea and that's affecting their quality of life, work-life balance and their scholastic performance as well as physical performance, so that needs to be addressed. Okay, number three, the story of a patient of COPD is frequently marred by frequent exacerbations, so that needs to be curtailed. The exacerbations should be reduced, dyspnea should be improved and hypoxia should be improved, right? Now how can we achieve these modifications? And also I forgot to tell you that the COPD is a progressive condition and we might need to think of measures to reduce the rate of progression, right? So let me start with the measures to reduce the rate of progression. The single most important factor that helps at least reduce the rate of progression is smoking cessation, right? As long as patient continues to smoke, the COPD will keep progressing rapidly. So for that, obviously you might have to have a psychiatry support and also medication support for the patient to quit smoking. So that we will discuss in the de-addiction topic later. But right now, remember, smoking cessation is one important thing. In terms of drugs, we don't have anything that can offer or slow down the progression of COPD or the hyperinflammatory state that it is. That cannot be right now curtailed with any medications. But this is one important intervention that we can do, smoking cessation. Now for hypoxia, what are the things we can offer? Obviously oxygen, right? So who is a patient that would require oxygen? When do we consider that? We will discuss, but we have to keep oxygen as one of the treatment options because hypoxia needs to be addressed. Okay. Now when you have to address dyspnea, mostly we think of offering them medications. And remember this one important point. Studies have shown that when you need to improve dyspnea that COPD patients experience, LAMA as well as LABA are roughly equivalent in terms of improving the dyspnea. If given a choice, I would probably consider LABA slightly superior to LAMA. It's a personal experience in improving dyspnea as a symptom. Okay. But now, when it comes to exacerbation, what's the best thing that we can offer? For a patient of COPD, if examiner asks you to pick up one drug that can be given to a patient of COPD, like for example, in case of bronchial asthma, we would say inhaled corticosteroids plus beta agonist if required, but the mainstay, because airway remodeling, all of that can be handled, inflammation can be handled by inhaled corticosteroids. So that's the main drug for an asthma patient. So if they ask you what is the main drug for a COPD patient, then your answer should be LAMA, right? Long-acting antimuscarinic agents. That's the main drug, right? Okay. So when it comes to exacerbation, LAMA is the best drug that reduces the exacerbation, and LABA cannot come close to it. LABA can improve the dyspnea but not the exacerbation, right? So we have to remember all these points because going forward we will apply these points in making a decision. Okay, now coming to the gold guidelines. In case of gold guidelines, there is a three-step approach of any case of COPD management. Step number one is classification of the COPD severity, and this COPD severity classification is based on post bronchodilator FEV1. Post bronchodilator FEV1. That means like you diagnose a patient of COPD using the spirometry. You do a baseline FEV1. After that, you look at the FEV1 by FVC ratio. Baseline FEV1 less than 80% predicted, FEV1 by FVC ratio less than 70%. Your obstructive lung disease confirmed. You do a bronchodilator reversibility test. The reversibility is less than 12% or up to 15% in selected set of individuals. You will call this case as COPD. After that, you will also do a FEV1 post bronchodilator. Anyway, for your bronchodilator reversibility, you would have done that, right? So you will look at that value for classification of the severity. Now, is our management decisions based on the classification of severity? The answer is no. Management decisions are based on mainly two important things: the grade of dyspnea and the extent to which frequent exacerbations are bothering the patient. And based on that, patients are categorized into 4 groups: category A, B, C, and D. So we will discuss that in a bit. But first, let us learn how do you classify COPD based on post bronchodilator FEV1 into mild, moderate, severe, and very severe. So when FEV1 is more than or equal to 80% of predicted, you can call it as mild or gold grade 1 or gold grade 1. Okay, when this FEV1 post bronchodilator, please remember this, it's always post bronchodilator, not the baseline. If this is in the range of 50 to 80%, 50 to 80% of predicted, you can call it as moderate or gold grade 2. Okay, and if it is between 50 to 30% of predicted, you can call it as severe, right? Or that will be called as gold stage 3. And when it is less than 30%, that will be considered as very severe or gold grade 4, right? Or gold 4 stage. So this is the severity classification. They might ask MCQs like this patient's PFT parameters are these, whether this patient should be called as COPD with mild grade or mild stage, or like the gold grade 1, 2, 3 or 4, right? So they might ask these MCQs. Okay, now coming to the real part of the management. So real part of the management begins by categorization of the patient into these 4 groups: A, B, C or D, right? How do we categorize? For categorization, we need 2 important informations. Number 1 information we need is the dyspnea severity. Dyspnea severity. Now, how do we assess the dyspnea severity? We assess the dyspnea severity by number 1, you have one tool, that is Modified Medical Research Council grade. And in this grade, you are looking at whether it is 0 to 1 or whether it is more than or equal to 2. And the second tool that we will be using is what is called as CAT tool, or COPD assessment tool, COPD assessment tool or CAT tool. Okay, so in this CAT, it's a long list of questionnaire that is handed over to patients, and patient chooses parameters according to his symptoms. Okay, so we will be looking at whether this CAT score is more than or equal to 10 or less than 10. So CAT score more than or equal to 10 or less than 10. MMRC 0 to 1 or more than or equal to 2. So these are the 2 batches how we will be dividing the patients. That's about dyspnea severity. I would recommend that you should literally by heart the MMRC component, because CAT tool is little complex in the sense we need to hand over a pamphlet to the patient and patient needs to take it. Not practical for an Indian scenario. So as an Indian physician, mostly we use the MMRC grade. And you might see questions where MMRC grade is generally mentioned and you need to assess, like the grade is not mentioned, instead the parameters or instead the patient dyspnea severity is clinically described, and you should be able to come out with the MMRC grade so that you can answer these questions, or you can categorize and then end up answering the right management choice. Okay, the second information apart from the dyspnea severity that we would need is history of exacerbations in the preceding 1 year. History of exacerbations in the preceding 1 year. How many exacerbations were there in previous 1 year? And exacerbation here means mostly I will be looking at moderate to severe exacerbations. Moderate to severe exacerbations. Now, what is a severe exacerbation? Any exacerbation that led to hospitalization. And what is moderate? Moderate is an exacerbation that required physician assistance or physician consult. Like patients of COPD might experience certain exacerbations which are like mild. Mostly patients self-medicate or do not need any assistance from a physician and it improves on its own. That can be counted as mild. If they had to go to a clinic or a hospital to take care, that should be counted as moderate. And if there was a hospitalization involved, that should be considered as a significant or severe exacerbation. Clear? Okay, so this is the 2 set of information we need: dyspnea severity and the history of exacerbation. Now let us plot this into the management algorithm, right? So if you look at this 4 categorization, you can see on this axis we are mainly plotting the MMRC or the CAT grade, and on this axis we are mainly plotting the history of exacerbations. So as I've already told you, MMRC grade 0 to 1 or 2 or more than 2. Those are the two batches, right? Any patient who has an MMRC grade of 0 to 1, as you can see, can only belong to two possible groups, that is group A and group C. And any patient who has MMRC grade of 2 plus 2 or more than 2 can only belong to group B or group D, right? So this is the direction. Same way I can say about CAT rule. CAT score less than 10, he can belong to group A or group C, and CAT score more than or equal to 10, he can belong to group B or group D. Okay. On the other hand, when you look at the exacerbation history, 0 to 1 moderate exacerbation and no severe exacerbation or no hospitalization, such patients can be categorized into in this direction, group A or group B. And those who had 2 or more than 2 exacerbations, moderate exacerbations we're talking about, we're not concerned about mild exacerbations, or even 1 or more than 1 severe hospitalization requiring exacerbations, that patient will fit into group C or group D. Right? So let us do this exercise by taking an example. So we have a patient, let me say patient is A. He had 2 moderate exacerbations in the past. He had 2 moderate exacerbations and he had 1 hospitalization apart from these moderate exacerbation, 1 hospitalization, and his MMRC grade is, let me say, 2, right? So which category he will belong to? In terms of exacerbation wise, right? 2 moderate and 1 hospitalization, significant exacerbation. So from the exacerbation perspective, he can belong to group C or group D, group C or group D. That's the direction. And from the MMRC perspective, he should belong to group B or group D, right? So we have a patient where this data intersects at group D. So we have a group D patient, right? So this is how we need to first categorize the patient into group A, B, C and D, looking at exacerbation history and looking at the dyspnea scale. Now let us look at how we manage the case after categorization. Now let us understand what are the important problems for these individual groups. Like let me start with group A. What is the main problem of the group A patient? Is it the frequency of exacerbation or is it the dyspnea? Probably both. I mean both not, right? Because dyspnea wise, he is still doing good, MMRC grade 0 to 1, and in terms of exacerbation history in preceding 1 year, right, hardly any exacerbation or maybe 1 moderate exacerbation, no major severe exacerbations, nothing requiring hospitalization. So you can say that this is a COPD patient who is generally doing well. Now this patient can be simply helped with any bronchodilator. Right? Remember what did we learn when we talk about the COPD management? We learned that to improvise the exacerbations or to reduce the frequency of exacerbation, the best class of drugs is LAMA. And to improve the dyspnea, LAMA and LABA are kind of equivalent, right? So remember this point when we try making problem statements. Now what is the problem of a group B patient? Group B patient, is he really bothered by frequency of exacerbations? No, because group B patients exacerbations would be 0 or 1 moderate and no hospitalization. But is he bothered by the dyspnea? Yes, he is bothered by dyspnea, MMRC grade 2 or more than that. So dyspnea is his predominant complaint, right? So for a group B patient, the predominant complaint is dyspnea. And because dyspnea is the predominant complaint, and we know that LAMA and LABA are roughly equivalent, you can choose any of them. LAMA or LABA can be chosen for the management of group B patient. Okay, now let us see what is the problem of a group C patient. The group C patient's problem is in terms of exacerbation, right? We can see that the MMRC or the CAT grade is not that bad, so he's doing well in terms of dyspnea, but his story is marred by frequent exacerbations. So he needs help with respect to reduction in the exacerbations. And what did we learn? For reducing the exacerbation, LAMA is superior to your LABA. So that's why we end up making LAMA as a choice for group C patient, right? So his problem is mainly with respect to exacerbs, and he can be better helped with the LAMA. Okay. Now, what is the problem of a group D patient? Group D patient is bothered by both. His dyspnea is severe and his exacerbations are also significant. Now, as we learn that LAMA and LABA are equivalent in terms of improving the dyspnea. So, when you prescribe LAMA to this patient, his exacerbations are definitely going to come down and he will also get a good benefit from his dyspnea severity, right? So LAMA as a alone drug can be started for a group D patient. So for group C as well as group D, you can start with LAMA. Okay. But selected set of individuals, you might consider using LAMA plus LABA combination. So GOLD recommends that you consider that in patients who are severely symptomatic with the CAT2 score more than 20. Right? Those who are severely symptomatic, them you can consider using a combination of LAMA and LABA, because this addition of LABA, though has not much of an impact on exacerbation, does improve the patient's symptom, right? So that is why Exacerbation, you still deal with LAMA. LAMA will to a great extent deal with dyspnea, but to help more, like in those who are having more severe dyspnea symptoms with a CAT score 20 plus, you can add LABA. Okay. Then you might also consider ICS plus LABA in those patients where the eosinophil count is more than or equal to 300. Previously also I told you, when you talk about COPD and you talk about eosinophils, we need to remember that it may be a case of asthma COPD overlap, and that is a set of patients where they might get benefited with use of inhaled corticosteroids and LABA, right? So without eosinophil count being more than or equal to 300, do not think of using ICS plus LABA, or even for that matter the triple therapy ICS plus LABA plus LAMA. There should be a decent elevation in case of the eosinophil count. So this is the starting point of a COPD patient. Categorize them into A, B, C, D, and after that decide what would be your initial prescription. The patient will definitely come back for follow-up after the initiation of medications, and then again you will make a problem statement for the patient when patient comes back for follow-up after initial prescription. So when they come back for follow-up, you have to look at whether now the predominant complaint is dyspnea or the predominant problem is exacerbations. Phenotypically, patient would have changed now. Previously, exacerbation was a problem, so I started with, let me say, LAMA, and when he is coming back, now exacerbations are no longer a problem, but dyspnea might be a problem, or in other cases, dyspnea may be an initial problem, so I started with LABA, and then exacerbation started becoming a problem. So these things can occur. So when the patient comes back for follow-up, you need to see what is the predominant problem. If dyspnea is the predominant problem, and if you had started with LAMA or LABA, you can choose a combination therapy. Initial point, like group C, you would have started with LAMA, or group B, you would have started LAMA or LABA, right? Now what you can do, if the dyspnea is a problem, the MMRC grade has progressed, then you can give a combination therapy, right? That's one thing you can do. Okay. Apart from that, you might consider LAMA plus ICS combination, as we have already discussed, when the eosinophil count is more than 300. Okay. You might even consider that if the eosinophil count is 100 plus and there are 2 moderate exacerbations more than or equal to 2 or 1 hospitalization. That's about the ICS LAMA. And you might use a triple therapy, right? LABA plus LAMA plus ICS. Again, when the patients have the same parameters, like eosinophil count is more than 300 or 100 plus with 2 or more than 2 exacerbations of a moderate intensity and or equal to 1 hospitalization or severe exacerbation. Okay. And these inhaled corticosteroids, we should make an attempt to de-escalate once the situation improves, because in COPD, they do not play an important role. Okay. Now, if when he comes back, exacerbations are the problem, how do we deal with it? Dyspnea is not the problem, it is the frequency of exacerbations. So probably the starting point would have been either your patient would have been either on a LAMA or a LABA. In that case, again, you can consider combination therapy. And ICS plus LABA, as we have already discussed, that would be considered in selected set of individuals. And if they are already on ICS or LABA, you might consider switching over to LABA plus LAMA, or switching over to a triple drug combination, because see, ICS and LABA is typically beneficial in a patient who belongs to what can be called as asthma COPD overlap, or where there is eosinophilic inflammation involved. Now the patient is coming with frequent exacerbations. Such patients, again, LAMA is an important drug to be added. So if patient was already on LABA plus ICS, you might have to think of switching over to LAMA plus LABA or LAMA LABA plus ICS. Okay. For those patients who are on LAMA plus LABA, if their eosinophil count is more than 100, right, in those patients you might consider using LAMA plus LABA plus ICS or triple therapy. Okay. If the eosinophil count is less than 100, you can think of adding 2 important drugs. One is roflumilast, your phosphodiesterase 4 inhibitor, which can be useful in patients whose FEV1 is reduced by less than 50%, and it belongs to a chronic bronchitis variant, right? So a chronic bronchitis variant with FEV1 less than 50%, that means your gold stage 3 patients, you might consider roflumilast. It is not going to be useful for the dyspnea because of emphysema, right? Okay. And in former smokers, use of azithromycin is also recommended by the GOLD guidelines, right? That can be like weekly pulse doses of azithromycin. The longest duration that we can probably use is 12 months, not more than that. And obviously, azithromycin having associated cardiovascular concerns, you should have to look at the history and maybe a baseline ECGs also to be considered, because we are using azithromycin for long term in these patients. Okay, so that's about the follow-up of a case of patient with COPD. Now, when we made initial problem statements, we also said that hypoxia is a concern and oxygen can solve that. So these medications, whatever we have discussed, LAMA, LABA, categorization, all of that is mainly to ease the patient's life. It's not about improving the mortality, right? Does LABA improve the mortality? Does LAMA improve the mortality, or these combinations improve the mortality? No. They can improve the dyspnea, they can reduce the exacerbations. But if you ask me what drug can improve the mortality, unequivocally the one drug that has proven effective in improving the mortality is oxygen therapy, right? So that's what we have already learned. We made a problem statement and said oxygen therapy is useful, right? So what are the patients who can be benefited with oxygen therapy, or when do you consider initiation? We use the term long-term oxygen therapy, and it is indicated in patients who have a resting SpO2 of less than or equal to 88%. A little higher SpO2 plus evidence of the pulmonary hypertension also warrants initiation of the oxygen therapy. So typical indication is patient with resting saturation less than or equal to 88%. It's not about exertion. At rest, if the saturation is less than or equal to 88%, you should offer them oxygen therapy. And those patients whose resting SpO2 is less than or equal to 89%. So from 88 to 89, we have given 1% relaxation in those patients who have pulmonary hypertension, or those who have already developed right heart failure, or those who have erythrocytosis, right? So this erythrocytosis appears for the first time in the current edition of Harrison. It's a newly included recommendation. All of these are markers of hypoxia and hypoxic influence on the cardiovascular dynamics. When you start seeing pulmonary hypertension, that means hypoxia, alveolar hypoxia, is already causing the pulmonary vascular constriction, right? Similarly, when you say there is erythrocytosis, we were talking about the pathophysiology, right? When we were talking about the pathophysiology, we did learn about it, that hypoxia will lead to development of polycythemia, right? So that's why we need to address these patients' symptoms with oxygen. Okay, so is that clear? We will be considering oxygen therapy in patients with resting SpO2 less than or equal to 88%, or less than or equal to 89% with additional factors in the form of pulmonary hypertension, right heart failure, or erythrocytosis, right? Okay. Is there anything that improves the mortality and morbidity to some extent? Yes. The second thing that improves the mortality is lung volume reduction surgery, right? So who are the candidates whom the lung volume reduction surgery should be offered? Basically, in lung volume reduction surgery, some part of the lung is literally chopped off so that the hemodynamics and lung dynamics improve, right? So obviously it's going to be helpful in patients not of chronic bronchitis but rather of emphysema, right? And it is likely to be helpful in patients who have emphysema which is not diffuse. If there is diffuse emphysema, you cannot chop off the entire lung, or by reducing some portion of the emphysematous lung, the remaining portion of the lung is still emphysematous, so that's not going to help the dynamics, right? So when there is variable emphysema, those are the patients who are likely to be benefited. First point that we need to know. Second thing is, operation wise, the upper lobe predominant emphysema is much more operable. So an ideal candidate is someone who is having upper lobe predominant emphysema and not the diffuse emphysema, or even when you say differential emphysema, not the lower lobe predominant emphysema, right? So upper lobe predominant emphysema is what we will be talking about for the lung volume reduction surgery. Upper lobe predominant. Okay. Now, the objective of doing lung volume reduction surgery is mainly improving the morbidity of the patient, and indirectly, to some extent, it does benefit the mortality. So, an ideal case is someone who is less than 75 years of age. His FEV1 is between 25 to 45% predicted. Post bronchodilator FEV1, 25 to 20 to 45% of predicted. Okay. So, less than 20% predicted. Studies have shown that it is associated with increased mortality, so cannot be considered ideal. Okay. In terms of DLCO also, it should be more than 20% predicted, because again studies have shown that less than 20% predicted DLCO is associated with increased mortality, right? So that we need to remember. Okay. Apart from that, this patient should be hypoxic. So an ideal patient with a partial pressure of oxygen less than 45 and carbon dioxide should also be less than 55. More than 55, less likely to derive the benefit. And as I've already told you, heterogeneous emphysema, upper lobe predominant, and already having limited exercise capacity. Someone who is having emphysema which is heterogeneous or differential but still has good exercise tolerance, they are not the ideal candidates for lung volume reduction surgery, because the main objective is not mortality benefit here. Mortality benefit ke liye oxygen therapy is the main drug, but the main objective here is the improvement in the functional status. And if already the exercise capacity is good, then they will not derive any benefit and the risks will outweigh the benefits. But those who have limited exercise capacity, when you chop off the emphysematous segments of the lung, upper lobes mainly, that will improve the lung dynamics, that will improve the patient's exercise capacity or dyspnea. Clear? Now, what can we offer to those patients who are having significant disease but they do not meet this criteria for the lung volume reduction surgery, like those who have diffuse emphysema, or those who have FEV1 less than 20% predicted, or those who have DLCO which is less than 20% predicted. What can we offer them? We can offer them lung transplantation. So an ideal candidate of a COPD for lung transplantation is someone who is less than 65 years of age, his FEV1 is less than 25% predicted, DLCO is less than 20% predicted, partial pressure of oxygen is less than 55 millimeters of mercury, and the carbon dioxide retention is there, right? Emphysema patient with a heterogeneous emphysema who we were considering lung volume reduction, we should also look at the carbon dioxide retention. Carbon dioxide retaining COPD patients are not the ideal candidates for the lung volume reduction surgery. So if the carbon dioxide retaining COPD patient is there, he better get a lung transplantation done. Okay, and then those who have pulmonary hypertension or call pulmonale, like eventually what is the only thing that we can offer is lung transplantation. Lung transplantation can be considered for all type of emphysema, including those with the alpha-1 antitrypsin deficiency. Okay, again lung transplantation should be considered in those patients who have limited exercise capacity. Again, lung transplantation is not something that would improve the mortality, rather operative risks definitely are involved. So the objective of lung transplantation is mainly to improve the patient's functional status. So those who already have good exercise capacity, they shouldn't be considered as an ideal candidate. Clear? Okay, now two more points to address about COPD before we wind up. Number one is, we were talking about this oxygen therapy. So how much oxygen would you give? Most patients would require around 1 to 4 liters of oxygen, and the target saturation is, target SpO2 is around 88 to 92%, right? So we are starting your oxygen therapy when your baseline SpO2 is less than 88% at rest. So we give oxygen just to maintain it 88 plus and not to exceed the 92%. So this is our target SpO2. Basically, we do not want to drive out the hypoxic drive that is keeping these patients breathing, right? Now, what duration these patients should take the oxygen support, right? So mortality benefit can be derived when the duration of oxygen therapy is more than 18 hours. Okay, now you have to remember, the maximum the better. Max the better. So if patient can be on oxygen for 24 hours, that's definitely going to be better. If not, at least 18 hours. And when it is less than 12 hours, right, there is no mortality benefit. No mortality benefit. Clear? So at least 18 hours is what I would consider good. If not, 12 to 18 hours, because less than 18 hours, it's as good as not giving the oxygen to the patient, right? Okay. Now the last point to address is with respect to vaccination. What are the vaccines that are recommended for a patient with COPD? Typically speaking, we know that we do recommend patients of COPD to receive annual influenza vaccine and then the pneumococcal vaccine. And in the current edition of Harrison, based on the even the gold recommendation came out with inclusion of the pertussis vaccine, right? So they included the pertussis vaccine as a new entry. So we have to also keep that in mind. This can be a potential MCQ. Which of the following vaccine is newly recommended for COPD patients? So the recommended vaccine is basically a combination of tetanus, diphtheria, right, and acellular pertussis vaccine, right? So this is recommended for all patients of COPD, apart from the usual recommendation of annual influenza and pneumococcal. And in the current context of pandemic, obviously COPD patients are also recommended to receive COVID-19 vaccine, right? So these are the 4 vaccines that are recommended for COPD. Okay, so that brings us to the end of discussion on COPD. We will be connecting with the next topic soon.